I'd like to call this meeting to order for February 10th, Health and Human Services Board meeting. Roll call, please.
Kay Wilson.
Here.
Tweed Schuman.
Here.
Marshall Savitsky. Here. Chuck Van Etten. Here. Jeff Haney. Here. Lorraine Gouget is excused. Don Pettit. Dr. Sabrina Dunlap. You have a quorum.
Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. May I have certification of compliance with the open meeting law?
This meeting was noticed to the media and public as required by Section 19.84 of the Wisconsin statutes.
Thank you. We have an agenda. The agenda has been set. Do we have any public comment?
We have a change on the agenda,
Oh.
just that D and B will just be presented together. Is that how I'm saying that? 13, D and B together?
Or 14.
14B, sorry. Yes, correct? Yes, okay. We're just kind of merging. We had some additions and it kind of got split up on there, so.
All right, I assume we can accept that change?
Yeah, I'll make that motion, Madam Chair, that we revise the agenda to include what was
Yeah, just to
stated.
adjust
D
the
and B on
order.
number 14.
Yes, that's my motion.
And I'll second that.
Motion's been made and seconded. Any further discussion? All in favor?
Aye.
Opposed? Thank you for that update. Any public comment? Online? No. Okay. Let's consider approval of the minutes from January.
I'll make that motion.
I'll second that.
We have a motion and a second to approve the minutes from January 6th. Any further discussion? All in favor?
Aye.
Opposed? So carried. All right, so we have consideration of appointment of a new board member to replace Carol Pearson.
Okay,
Mike
so
or Julia?
Pam Mueller is here today. She has, I think you have a little bit that you can say about yourself as you move forward. I thought we'd just kind of let her present herself.
Okay.
She's interested in joining the HHS board with us.
All right.
To replace Carol.
So turn on your
remember
light
your
and-
speaker. The face one, the middle one. Yep.
Okay.
I brought her down here just to get her acclimated a little bit to this boardroom.
That learning curve. Okay, my name's Pam Mueller, and I've lived in Hayward since 1987. I live in Round Lake Township, and I've worked for Sawyer County for 20 years in child welfare. I retired in April of 2016. I worked as a social service aide and also the coordinator for the independent living program for foster youth age 15 to 21. I'm currently on the Sawyer County Housing Authority Board for, it's about 6 years now. I volunteer at the Northwoods Community Food Shelf up on Highway 77 past the hospital. And I job coach 4 mornings a week for Ventures with disabled adults. I have a grandson who was involved in birth to 3 and family support through the county and now attends Ventures. I'm also a Chequamegon Lions, and I guess that's about it.
So she has pretty extensive background coming to us, so I'll leave it in your
That's why I
hands.
made the recommendation. So how do we go about this? We make a motion to accept Pam as a new
Correct.
board member?
Yep.
I'll make that motion.
Okay, and I'll second it.
A motion's been made and seconded to approve Pam as our new member for the Health and Human Services Board. Motion's been made and seconded. Any further discussion? All in favor? Aye. Opposed? Welcome.
Thank you.
Thank you, Pam. You got beat out on your second today, Marshall.
Okay, let's see. Lorraine is in Madison, I understand, so do you have anything to report on the LCO? Do you have a report
She
from
did
her?
not give any report for
Okay,
me, so.
all right. Any report from the Senior Resource Center?
There is information here. Do you know about that, Liz? Or does anybody?
I'm on the board, and I got a written report from Joey, and we can start attaching that here if you want to have continuity with written reports from them.
I think that'd be a good idea. Yeah. And Pam, when you're not speaking, do you want to turn off your light? There you go. There we go. So do you want to read that report to us then? Or it's there?
It is on our agenda.
I guess so.
I don't know that
It's
is
not,
in there.
it's not attached.
It's not in there.
It is, I clicked on it right here, Senior Resource Center, HHS report. This is it.
Oh, never mind. It's on
attached.
page 6.
Oh, I see.
Sorry, I went right by it too.
Is that it? Is that it?
Okay. Any questions on that?
Okay.
Let's move on to administration.
Okay, as usual, your acronyms are in here. I included the org chart that we said would be a standing item with any changes that we have noted. Anything that is in the blue highlight is something that was new from last time. So we do have Melody Jorgensen as a disability benefit specialist. She's works for, or she supports Sawyer County half-time, but she's actually employed by Price County, so it's part of the consortium. And so that one is new. And then for transitions, under the Behavioral Health Division, we did hire a casual, Katrina Grandadam, as a resident assistant. And then we do have what is not noted on there is we do have an open position for day shift at transitions. And we will then be needing to hire up as we transition our clientele there. The other thing that is not noted, or it is noted as vacant, I probably should have highlighted that. I don't think that was on last time. We have a position in environmental health, our casual position or our LTE position for environmental health specialists is open. That's a seasonal position to help us keep our numbers up in the summertime. So we have that one posted as well. And then the other two new things that are coming up is Lisa Nasser from the Birth to 3 program. She's our program coordinator, has put in her resignation as a retirement. And then over in the Businesses Services Division, Melanie Roloff, admin assistant, has also put in her retirement. So I think it's going to be a busy year for HHS and transitioning staff. I don't know about any other staff, but I do have staff that are kind of retirement age that could be coming up. Yes.
Julia, I see we have Joe Bodo as our Chapter 51 consultant.
Yes.
Is that going to be able to carry the load? I mean, I know Joe's been very busy, and didn't he retire too? Or?
Yes, so he retired. I was going to wait until his section came up, but
Oh.
we're going to, behavioral health, but we might as well cover that right now.
That's very important.
It is very important. And actually, Joe is on as consultant. We're going to continue to contract with him this year. I could not do all the legwork and everything that is needed to keep those commitments rolling and everything with Duffy's office without having Joe or somebody in Joe's position at least handling that portion of it. I think we're getting in a pretty good spot where Joe and I are making fairly close to the same decisions that as we move forward. So I think he's taught me that over the last year, but just being able to pick up that amount of legwork would not be able to do that. The other new thing, just speaking about Joe, is that he is not only working as a consultant for us, but he is just coming on as a casual employee as well to do mental health therapy with our CCS program, or AODA, as we get that up and running. So it just gives us that person right here ready to go. So he'll only be working in the office when he has appointments scheduled, so.
So much for retirement,
Yeah.
huh, Joe?
Had a nice new ID, but they gave me my old number back.
So at this point, that's how we're handling it. Should Joe decide to 100% retire, at least I'm kind of got that piece in there where we can kind of start to transition and think about how we would handle those cases.
Well, I just asked that because that's such a very important position as we wrestle with these out-of-county placements and how we're working to make the county more efficient and build up this other home we have, right?
Right.
To take those?
Right.
Okay.
So Caitlin, as they start talking too, so Caitlin's Northland Counseling has really stepped up on the mobile crisis piece. So Joe managed the front end on some of those pieces, then they managed kind of the back end. Northland Counseling is in there right away, or Northland Community Services. She's got both names for the company, are there right away at the hospital, managing those things up and then following up on the 30 days. So we've filled in some of those gaps along the way as we move forward, but it needs to be on the forefront. I think it's been really helpful that I have had to be in every decision because I can really understand what's happening at a county level, be able to find different scenarios. And as we walk through, let's wait till we get to behavioral health. Well, actually, it is part of the admin report where I was going to say that. So I can kind of keep moving in off of the org chart into the admin update and thinking about the IMD. So that's those behavioral health places that are 16 or more beds that we're not able to bill medical assistance for between 21 to 64. Part of being in every kind of decision-making and seeing things really in a fine tooth, we found some things where we are getting some people into an IMD when they have private insurance, that's fine because that covers that service. But if they have medical assistance, it doesn't. So what does that flow diagram look like and how do we manage that? It's putting more strain on mobile crisis when they're really needing to be dealing with where do I get this person placed and get them move forward. But we are going to need to come up with some type of flow diagram. So, we can say, oh, they have medical assistance. These are the ones that would cover, so the county doesn't have to cover if they are willing to take them, because that's the other piece. A lot of times nobody will take them and we have to go to Winnebago. But if they're willing to take them, do we go this? If they don't have insurance, where do they go? If they have no insurance, what's the best financial decision-making from the county perspective? So we're going to be working through some of those pieces too, so. That's one of the things under the admin update. The other thing that has come to my attention, I have to say I'm not really good about scouring the county record all of the time and looking at different notices in the notice board. But what we have noticed is that we're getting some child abuse information on the criminal side that is actually giving away information on the child themselves, maybe not the name, but more information. These probably should be confidential or sealed, but they're going through as open records. And then they're getting requested by the press. I had just heard about this from another county and they were like, I don't know what to do about this. And then it just came to my attention just this last week. So be working with Sherry Jensen and Marge on trying to come up with a plan that will potentially work, that we can either seal records or make them confidential so that they don't come forward. Because anything CPS investigates is marked confidential. That doesn't come through. But after it gets through and it comes on a criminal side, those things are getting missed of being marked confidential. So, and it's such a small area, it can be pretty obvious on which child is being talked about and being removed, so.
Could that be considered as a HIPAA violation? I mean, those are very serious and
Yeah,
serious
but
penalties.
we didn't release the information.
Right, but
Yes.
somebody did.
Well,
Or they-
it's public record, so that's the problem. So how do we keep it out of the public record? So we have to try to identify something to keep it out of the public record. So anyways, that's just another admin thing that I'm working on and hoping to have a plan. It could be starting with the investigation on law enforcement side, marking it as confidential. I don't even know. I'm just not a part of all of those different pieces, but I think we're getting the right group of people together to come up with, how do we get it up through, so by the time it gets to Marge, or whoever would release records, that they would know it can't be released, so, or shouldn't be
We
released,
don't
or
need
should
to
be redacted more.
read all that stuff anyway.
So anyways, it's not just our county it's dealing with that, but kind of a new way, I suppose, of how the press is going through looking for information. It's a new way that we didn't realize was happening, and now other places are starting to see it. So we need to address that. So just one of the other pieces on the administration side that we are working on. And then the other related to HIPAA is AI, and that is a slippery slope on using AI and keeping protected health information out of AI-generated things. So like GPT is, if it's a free version, anything can go out there. So anything you do on AI personally, it's just going to go out there, and anybody can see it as long as it's not one that is actually meant to be protected with a business associate agreement and HIPAA compliance. So I'm going to be going to a one-day training that I heard was really good, put on by UW Extension in Eau Claire. I'll be doing that in March. I'm also listening into the, and I don't know what the acronym is, but HIPAA-COW is a Wisconsin association that works on, I know, isn't it? Weird things. I don't know what that means. But they work on all things HIPAA related, and then they write policy that's specific to Wisconsin that we can feel very confident on moving in to our own areas. So have been listening in on those, have one policy ready that looks like it's ready to go. I know another policy I just listened to looks like it's coming forward. I just did, or tomorrow, those of you who are on my team will be getting an email notifying that any AI and PHI cannot be used together until further notice, until we are able to get a platform that we're able to use AI. It is very helpful for documentation. When we go to if I go to write a paper or I'm writing something and I can use an AI component to it, it's much quicker, it's cleaner, our documents will look better when it comes to court documents and everything else. We just need to come up with a way to be able to do it that's HIPAA compliant. So that's on the radar as well. So that's it on my admin update. I do have a strategic plan in here that I can just go over and do some highlights on. For the goal of employee engagement, the January event where we had the all-staff training went well, and staff will be looking forward to another opportunity next year. We will be planning an all-staff, hopefully in June. We're trying to identify those time when we can do an all-staff just for HHS in June. We talked about staff appreciation as another strategy. We had quite a few blue ribbons put forward at the end of '25, so we'll be starting to track those for '26. And supervisors are starting to use those 30, 90, and 65-day plans. And so we'll start to be able to garner information off of that. Page 18, when we talk about efficient processes with the electronic record. Just met with Alicia and Allison today. We'll be opening up clients that we have mobile crisis on. That way we can start documenting those and those that are under commitment and settlements. It'll help us for tracking and then be able to kind of strategically move them into other things that might be open for them with the agency, like CCS or CLTS or CST, all of the C things. And then birth to 3, when we talk about the centralized referral process, part of being able to do that is getting everybody documenting in the system, and birth to 3 is now coming on board as well. Page 19, when we look at the reduced mental health out-of-home costs, I brought in a couple of strategies that I had just talked about in the admin, but specific to transitions, we've been meeting with the client every other week. Joe, as a reminder, we're doing our virtual visit tomorrow with her. So we're going to take a virtual visit at transitions with the client to identify any changes in the environment that we need to be thinking about. Our staff will also start meeting with Winnebago. We meet with them already, but I want staff that's specific to transitions to be meeting with staff that are working with the client daily. And then we're working on hiring. And then increasing revenues, we've have established that a weekly meeting where we're going to start discussing the C programs, and that is with Northland, Joe, Alicia, and Allison to make sure that we're transferring everybody in appropriately. And we have identified a new staff member that will be trained in CCS for billing purposes. So that covers strategic plan update. Does anybody have any other questions?
Under that increasing revenue streams, are you going to add, is that looking at insurance premium or no? Insurance payments to us?
Also insurance payments to us. So one of the things that Carrie's been really good at doing is if somebody has private insurance and we can bill, like for billing purposes. So like, give an example, birth to 3. For quite a while, we weren't billing birth to 3 private insurances because we were not under their plan. And so they've been working hard to make sure anybody who brings in an assurance to us that we're getting under their plan and can bill at the highest rate.
So that we'd be a preferred provider
A
then?
preferred provider, thank you.
Correct.
I had lost that
Yeah,
word.
right.
That's what we're
But we're
looking
not
for.
going to charge our residents or people that use our system co-pays or anything like that?
It's.
Is that part of your revenue plan?
There is already, so there are copay, so if you're, just give birth to 3 as an example, not all programs are like that, but birth to 3 does have a copayment to it. If you have private insurance or you don't have any insurance, there is a copayment. If you have medical assistance, that covers the whole thing. So it just depends on somebody's insurance plan as they come in. If
Is that
people-
another roadblock for our people though? I mean, so they,
To get into the programs?
right,
I would say no.
okay.
For the most part, it's not, it's very nominal.
Oh, okay.
Co-pays are very small.
It's very nominal, yeah. And if somebody say they're, for birth to 3, say they have private insurance and most insurances are covering it. Some of them have a copay with it. But if they, even with the no copay, it's a very minor amount that would be paid with that. And we'll make sure that people can get the services, but we also want to make sure that if we can bill, we're billing and getting that refund back. So kind of working through that strategy. Other questions? Okay. Hearing none.
Can we move on to behavioral, ADRC?
Yep, we won't have a report for that. Carol is out of the office.
Okay.
But what I can just let you know is that APS is still going pretty hot and heavy. It was going strong in the fall, still going strong. We had communications going back and forth between Northland because they're getting kind of bumped into this because of mobile crisis, even though they're technically more of an APS referral. And how do we kind of get them into services? So we're hoping that next week during Berkey Week would be a good time to have a meeting. Have to be via Zoom because we're not moving vehicles away from here. But being able to connect with the team to kind of look at how can we better streamline these, what can we do The really difficult part is just finding a place sometimes to place a client. So, but I think that we definitely can fix some of the roadblocks in there. So that's really the focus on the aging and disability area that's really bubbling to the surface. The other thing that we've been seeing a bit of is youth that are turning 18 that are actually coming out of CPS world or YJ world and needing to transition into the adult world. So that's that connection with the ADRC on what type of resources would be there. That's it on that report.
Okay, Alicia has a report for behavioral health.
Alicia, I think a lot of your steam might have been taken out with some of the things. Do you have anything else to add?
No, I think you pretty much covered it. Unless somebody has any questions on what we're doing. One thing that's not in there, which I've really been spending a lot of time on, is I think what I'm going to be doing is integrating our 75 and 35 license into one, where it's the integrated behavioral health license, instead of having 75 and 35 separate, where you have to open up a client under both chapter or administrative code. It just makes more sense to do that. So I received more answers after I put this report together, which it's going to be an undertaking, but it's not that it can't be done. It just takes time and a lot of time to write the policy and procedure. But that way we only have to pay for one license. It'll save money and also time when we have somebody that presents with a co-occurring disorder, both mental health and substance use disorder. So that, I think that's what I'm going to do for that, Julia. I finally got an answer. So.
Yeah, that sounds good. So we have mental health and substance use. There's two different statutes that they can fall under, but they've also have a combined one that came up after. Obviously, as you heard, there's been a lot of discussion. So it's a lot of behind the scenes. It doesn't really change a whole lot for the person who's presenting to us. But what it does change is all of the stuff behind the scenes and risk for us as well. So.
Julia, we're also trying to reestablish our CCS program?
We've
Is
had.
that what you mentioned with Mr. Bodo?
Yep. So being
Okay.
able to.
And that would be part of your revenue stream you were looking at too?
Yeah, that would help with revenue stream. Being able to keep those clients in and move them forward will increase our revenue stream. And getting them into that specific type of programming. The
And being
other-
able to bill
And be
MA?
able to bill, we bill for all of those services that are being provided. The other thing that we're looking at is being able to CCS qualify other staff who also can have billable hours that are already staff members, so. But we need a therapist in that it helps it helps to push. So as soon as Caitlin gets that referral, she's seeing somebody who under crisis, they've gone to a crisis bed, maybe they've done it a couple of times and it's like, okay, safety planning and coming out isn't working, we need to get them into CCS. They're not CSP level where there's, major psychosis and medication, but they're really just needing to kind of change those behaviors. Being able to give them a therapist right away to be able to call and connect with here and connect with the facilitator should make things a little bit smoother. One of the things we've identified, and Caitlin, I don't know if you were going to mention this when you talk, but we've run up against a barrier of having plans in place, thinking we've got it all set for Northland to do the communication. And the behavioral health unit is confusing Northland with North Lakes and calling North Lakes. And then we're having a problem where they're calling and they're already finding out that through their discharge planning, they've actually scheduled something with North Lakes, which then just creates a mess for us on our side because we can't give them any of these other services because North Lakes isn't CCS qualified. So
Too many Norths.
Too many Norths. I know she's talked about wanting to change her name, but oh my gosh, that would be hard too. So anyways, that's kind of some of the barriers that we've been butting up against, but I think we're getting some things established and reconnecting on some of those. So if you don't have any other questions for Alicia, we can move into the 2025 mobile crisis review. I'm going to have Caitlin come up and give a review of the data.
Hi, I'm Caitlin.
You can move that mic, so you're tall, holy cow.
Well, I'm wearing heels too. I'm not much of a public speaker, so I apologize in advance. But I'm with Northland Counseling, and for about a year and a half, 2 years that we've done the hospital.
Yeah.
So we have always worked, or not always, but for several years, we've worked doing the mobile crisis assessments with Sawyer County. But about a year and a half ago-ish, Tamarack Health had contacted us to do a contract for the assessments for those voluntary people seeking mental health services. And so Julie and I had spoke, and we wanted to make sure that you guys were getting the full picture of the true mental health crisis needs in the community, counting those voluntary assessments. And so that is what these numbers are. So counting both county referrals and voluntary hospital services, we did 209 mental health assessments. Then we broke it down. So by referral source, the vast majority were referred by the ER. And Joe Bodo thankfully brought the 2024 stats, and the number for the county looks about the same. Then on the next slide, this one talks about just county consults. So when Joe sort of retired, now instead of Joe being that point of contact for law enforcement, I've been fielding those calls. And so this breaks down which ones I've been able to resolve over the phone, maybe without needing any sort of assessment or follow-up. Or even there's been situations where I've made safety plans over the phone with people as well. So overall, that was the total number of calls that I received. We also wanted to break down how many people have repeat assessments. So that was something that was helpful with Northland Counseling taking on that hospital contract, is we were able to notify Julia and other programs how many people were coming into the ER, maybe folks that were coming in voluntarily, but then later on it becomes something where law enforcement's involved. So you will see most people we only met with once and got them connected, but there were a few people, 17, that had at least 2 assessments, and then I think that's an 8 for
It is an
3 plus. There were some individuals we met with more than 3 times.
So those are the individuals, those 2+ and 3+, that we want to be able to identify and get into programming to keep them out of that system.
This one, that's okay. That was just a breakdown by biological sex. It was vast, most were women, almost even, but most people we met with were females. And that's all that's on that slide. The age range, so we have noticed, I think as Julia mentioned previously, that we are starting to assess more individuals that are 65 and older, and that has presented some new challenges. Even when older individuals that fall in that age range have maybe a mental health history, if they have, medical needs or maybe need help with their daily living activities, it has been very challenging to find any sort of inpatient treatment for them if that's what they're needing. And then I know we've also had some folks in that teenage range that I've been able to connect with Sarah and other folks to get them into more programming too. We also broke it down by different counties, so most of the people we met with were Sawyer County residents. We do see a lot of Washburn County residents, and only a handful of Bayfield, even though we're pretty close to them. A couple out-of-state folks too during the summer seasons.
And those are the ones that present a lot of challenges.
Lots of challenges, yes. And then this just kind of broke down why we were being asked to come meet with them. And you could probably break this down a lot more than what we did, but we didn't want to overwhelm you guys with information. the vast majority were for suicidal ideation or some sort of suicidal behavior. But we did meet with quite a few folks that also were experiencing, hallucinations, and then there are some up there too, quite a few where drug or alcohol use was also involved in the assessment. And I think this is the last one, is the outcomes. So it was almost even between the safety plans and the voluntary admission. I will give kudos to Tamarack Health. I know a few years ago, a lot of behavioral health units have been requiring secure transport, and that was a huge barrier. But they have actually been covering costs for families to send children or the adults, whomever may need it. They have been really helpful in setting up secure transport through the hospital. So we've been able to do a lot more voluntary admissions that maybe in the past we hadn't been able to do. And we also do a lot of safety plans, so just connecting people with resources, kind of talking to them and their families about how to keep them safe outside of the hospital if appropriate.
And just a reminder that secure transport from the hospital to the behavioral health unit is required on the behavioral health unit side to make sure that, that we can get them there without them ingesting anything or anything that would make them medically unstable by the time they get to the unit.
Where is the behavioral health unit now?
All over.
Well, unfortunately, with where we are, the closest is Ashland, but they are a very small unit. So we do not, unfortunately, admit a lot of people there. The next closest would be like Duluth or Eau Claire, and then after that, you're looking at like Green Bay, La Crosse, quite a distance. And so a lot of families, that's one large barriers, especially for children and adolescents. That list is even smaller, and those units are even further away. And so a lot of families couldn't afford to bring their children to the hospitals if needed, and so we've had to get creative with the hospital on how to get, consent signed, get the children there safely. So we've had to do a lot of strategic planning with the hospital, or even, if hospitals are willing to do paper consents, I'll have them fax them to my office, complete them. Because, that's the biggest barrier for children is the distance.
Kaylin, are you always on call? Or do you have someone that relieves you?
I'm always on call with law enforcement, but I do thankfully have 4 individuals working with me that are equally as passionate, so we've been able to make it work. I do most of the daytime assessments, and then we rotate the after hour and weekend on call.
She works a lot.
Yeah. So this is why also that APS is so busy, and
As you can see, her numbers,
Yeah.
then that's pulling
With the
in
elderly now
APS,
that's climbing
yes, and it's alarming. So when we just had a major struggle just this last week, thinking we were, had a plan, and that plan fell through, but hopefully everything is
Knock on wood, haven't heard anything. So.
So there's definitely lots of obstacles when people are over 65, have those other health conditions, dementia, Alzheimer's, and other things. So, and especially if they have behaviors of aggressive behaviors makes it very, very difficult to place.
It would be interesting in the presenting problem to see the age breakdown.
Oh,
that too.
off of well, there's your next data dive when you guys do that. I'm not
the numbers
surprised.
person, so we'll add it to his list.
I would just be curious, but it's certainly not something that I would be demanding or anything.
I will say, like, just off of memory, most of those folks that we assess 65 plus, I've worked really closely with Rebecca and Carol to get them in on it right away to see if we can do, like if a guardianship or some other avenue is more appropriate than doing like an emergency detention. So I would say we've probably done mostly safety planning with those individuals. I know there have been a few where I've actually found a facility that specializes in geriatric behavioral health services, but they are in Stoughton, Wisconsin. Oh, there we go. Sorry. I don't even know where that is. I know it's a ways. So I know we've sent, I think, 2 individuals there, and then another gentleman went to the VA.
But all these interventions early on prevent,
The earlier we
Winnebago in the end.
can identify, yes.
yeah. So thank you, Caitlin.
Yes.
Thank you.
That's always the trick. Got to get in there. And you have to want them to be willing, because we can't force them to do it unless we put them under commitment or settlement. We really don't want a lot of people on commitment or settlement either. So settlement, not so bad. Commitment, so. Okay, thank you so much.
Thank you very much.
The other 2 reports are reports that you're used to seeing. There isn't anything that's standing out that we haven't talked about before in those. Unless you have any questions.
No, but that's, the monthly expense report, that's complete for 2025 now.
We should have most expenses in, and revenue is still going to be trickling in as well. So, because we still have billing out from MA and different things. So Winnebago, especially, we can get some costs kind of trickling in over time too.
Okay,
Mr. Markren, so with what's showing up here now so far in 26, did we budget the right number for?
Well, it's early to tell. We did end up going over budget on a couple things in 25, so.
Right.
Hopefully we can transfer some money to HHS once we get the books pretty much closed from the general fund to give us a little boost to start the year, but time will tell. It's early to track it, but we're hoping with the changes that Julie has led, we can make budget.
Okay, thanks.
all right, can we move on to Child, Youth, and Family Services then?
Yes, we can. Okay, so on the first part, I put in a couple of reports under Child Protective Services. Just kind of overview of 2025. We received 263 reports, and we screened in 96 of those. So 36 of those reports were screen-ins. The other thing I wanted to point out on this particular report is the response time, where it says same day within 24 to 48 hours and within 5 business days. When you screen in a report, it tells, based on what you're screening in, it says how quickly you need to get the investigation started and going. And so response time of same day was about 18% of them we needed to like get in there and get something investigated. But as you look through, and then all of our screens, we screened in within 24 hours, 85% of those cases. So that is those. When we move into page 35 on the removals. You can kind of see what we've been removing ages. I'm getting on the other, and then the documented removal reason. So 14 children were removed. There's a total of 15 removals. That means one child was removed twice from their home in 2025. Average distance is 59 miles. So if you think about anybody who's in foster care is going to be really close to here, not that many miles. So it kind of tells you how far, when we have like RCCs or residential care or detention, those kids are quite a ways away, and our staff have to go and do face-to-faces with them. So all of those types of out-of-home placements also adds to road time for our staff, and it also makes it more difficult for their parents to be able to connect with them if they're still kind of in that picture to be able to connect with. So those are kind of the things that as a rural community up here, we kind of deal with a little bit differently than counties that, like Eau Claire County, everything is a little bit more close to be able to manage. You can see behavior problems, child behavior problems. There's a number of reasons for coming out where you kind of think more on like neglect, but really kind of seeing where kids just aren't as manageable and we're struggling with, or there's drug abuse. Obviously, we do have child abuse and neglect in there as well. And then quite a few removed at age 15 plus. Okay, that is page 34, 35. So moving on to 36. Discharge, 15 children were discharged. Total of 17 discharges, meaning that somebody was discharged and then brought back in. The good thing is 9 were in reunification. So that's really what we want to be able to see is kids getting back into their homes. And then when you see the final, let's see, I thought I had the age at discharge, 15 plus, we had 12 of them. One of the things that we're seeing right now that's been fairly new that we've been kind of trying to manage up is we have kids who have been in the foster care or in some type of placement and are actually turning 18 and coming out of the system and don't really have they haven't been adopted or they don't have a guardianship, and we're trying to kind of manage those and move them into the adult world, which then gets us connected with the ADRC. What's happening with them? Do they need a guardian? How do we get them on their feet and moving forward? We've had a few who have been institutionalized for many years. Institutions don't prepare people to be out in the world. So that's some of the things that we're struggling with and trying to work at, finding other options on getting them prepared to go out. And then finally on page 37, it just did a trend line of time of showing out-of-home care over time. So starting in 2020 to 26, you can see that we have been really trying to make that reduction in the amount. Even though our numbers are high, we've had expensive pieces, we've also been bringing that out-of-home care down. So that's the report for Child Protective Services. Any questions on that? Okay, hearing none, we'll go ahead and move into YJ, and Sarah will come up and give her reports.
Hello, everyone. So the numbers report for, let's see, December of 2025, we only had 3 total referrals. I think the numbers kind of speak for themselves on this report. The only things I would like to really highlight is that at the end of December, we had 39 open YJ cases, and December was the first time since I became a supervisor that I no longer carried any type of caseload, which was a huge relief to me because doing both was very challenging. The other thing that got me really excited, and I kind of went running to Julia's office and I was like, you got to see this data. And so what I had pulled was in 2022, we had 75 YJ delinquency referrals. In 2023, we had 80. In 2024, we had 76. Last year, we had 58. So I think that speaks volumes to the work that we're doing and really reducing those referrals. And I think a large piece of that is because of the diversion program that has been implemented. And I think we're only going to continue to see like more and more, like, I guess, decrease in those numbers and showing the work that we're doing as being successful. The next thing I was going to go into is this deep data dive that I know I touched on last time that I was present for the board meeting. And this was something that we did in conjunction with kind of the state guru in youth justice, Jenna Dunlap. And so we spoke with her and we were able to have her kind of do a deep dive into gathering some of this data for us. So the data within here is a lot of me pulling from her report to really highlight the things I wanted everyone here to be aware of. If you look at that first graph, this is saying Sawyer County has a higher than average rate of delinquency referral. And this is our youth ages 10 to 16. So if you look at that dark blue line, all of those other smaller gray lines below it are all of the other counties that have a lower delinquency rate than we do here. There are very few above us, and I think that's very noteworthy. If you look at the Wisconsin map, to the right of that, you can see again that Sawyer County is highlighted to be in the most, I guess, referrals within the state of Wisconsin as well. The data revealed that Sawyer County is consistently among the top 7 to 10% of Wisconsin counties with the highest rate of delinquency referrals for 1,000 youth ages 10 to 16. So below that, it just kind of reviews what the graphs are saying. The line chart on the left shows that most counties are in the 12 to 25 referrals per 1,000 youth range, and Sawyer County has a higher rate of 35 referrals per 1,000 youth in 2022 and 23. It states this rate has dropped to 29 referrals per 1,000 youth in 2024. Compared to the state as a whole, Sawyer ranked 5th in 2022, 5th in 2023, and 7th in 2024. The map on the right shows how Sawyer County's rate of delinquency referral compares to other counties. Small counties are in the blue, where all other counties are in the gray.
Can I ask a question?
Sure.
What's your definition of delinquency?
So delinquency is considered like a non-status offense. So when I say status offense, I'm saying the kids that are runaways or like habitual truancy, those are more status offenses. So when we're saying delinquency, it's criminal-related charges. So we'll get, I think it's 2 pages after this, the next page, but it goes over what the charges are that we are seeing as the majority in Sawyer County with 38 point, I guess I can kind of jump around on this a little bit. Okay, so this shows 38 point, or I'm sorry, I'm reading it incorrectly. 50.7% have been charged with what's considered other. So attempted homicide, substantial battery, possession of firearms are all grouped into that box. With battery being 28%, disorderly conduct being 42.7%, criminal damage to property being 21.3%, resisting, obstructing is 10.7%. So it's really more of those more criminal type offenses.
Thank you.
You're welcome.
I have a question on this one too. Do we get together with other counties at all to work on best practices or anything, or brainstorm?
Julie and I, after this meeting, we had said that we wanted to set up a meeting with Vilas County because that is the most comparable county that is similar to ours, and just to talk about how they are doing things as well, to see if there's anything that we could piggyback on.
Actually, I noticed over these 3 years, they went from 48% down to 30%. So that's pretty good growth in Burnett and Ashland as well, which are pretty local. That's
I think
pretty
we
good
have,
growth.
like, whether you're saying Washburn, I have a hard time comparing
Ashland, not Washburn.
Ashland.
Yeah.
I think our best results, and like talking to someone, and this was specifically from Jenna, is Vilas County has the similar needs that we do and is the most comparable. Not that I'm not open to talking to Ashland or Burnett, but I would definitely like to start with Vilas County and work down.
We are on like regional calls and we do different things like that, but to specifically deep dive into programs that they have. And it's really, most of the time, it's external from the county. It's things that are happening within, not what the county is doing, but what's happening in that area,
All right. Thank you.
if that makes sense.
Yeah.
And that's what we need to kind of figure out.
We do have, like, the supervisors have our own regional supervisors meeting where it's like the northern region, and we do get together and talk about different aspects. I'll leave, I was going to add an opinion, but I'll leave that out. So, okay, moving into, yep, that page. If you could go back up a little bit. Yeah.
Right there.
So this one is saying, in comparing rates of delinquency referrals across small counties, Sawyer County ranked 5th in 2022, 4th in 2023, and 5th in 2024. The most similar counties in youth population size are Ashland, Langlade, Richland, Vilas, and Washburn. And you can see those different counties outlined below. But again, Sawyer County consistently falling in the very top range within that. The data dive also showed Sawyer County's delinquency referral burden is higher than the state average, but not drastically different from similar sized counties. In terms of rate per youth population, Sawyer County is among the highest. In terms of raw counts, Sawyer County consistently ranks 4th among small counties for the highest count of delinquency referrals in 2022, 23, and 24. And I know in past meetings, I've come and I've kind of, gave all the verbal kind of explanation of what things look like here, but I think it's very important for you guys to also see the data and the numbers associated, so it's not me just coming in and talking about what I'm seeing, but there's data tied to it as well. I talked about the next page already a little bit. Towards the bottom, I just want to highlight, so as a reminder, we use a YAZI assessment when we have youth come in, and that helps us gauge their risk level when working with them. And so what is important to see here, and I know this is another thing that I have brought up in previous board meetings, but the data now also supports that, where when you're looking at Sawyer County, which is that lighter blue, bright blue, the low to moderate risk, we are significantly lower than the rest of the state. So we aren't seeing the low to moderate risk as often as other counties are. We are seeing, if you go more to the right, the high risk, the very high risk, where other counties are lower than what we have. We are very high in those areas for that very high risk need. And when we start talking about high risk, very high risk, this is really looking at the amount of work and time that it takes for a case manager to do that individualized work with them, because their time is more demanding. Rather than seeing kids, once or twice a month, we're having to see them sometimes every week, sometimes more than once a week. And if they're going out of the home, now our workers are on the road with that travel time and spending a whole day doing travel to make sure they do their face-to-face on a monthly basis. And so I really strive to, meet those standards, and I want these kids and families to know that our department in youth justice, diversion, we are doing really significant work, and we are doing work the right way, the quality way, and it's requiring a ton of time from these workers. I can't tell you how many times, like whether it be a residential facility or a group home that says, wow, your unit, you can tell you guys really care. You are showing up. Other counties are not seeing their kids as regularly. They are doing Zoom visits with them, which isn't that quality of work. You're not going to build that substantial relationship. And if you can't build that relationship, kids aren't going to care of what you're trying to put in place for them. So point being, I think I just give my unit a lot of kudos, like I usually do, but they're out there, they're doing hard work, and they're doing it better than most from what I can hear as feedback from other placement facilities. So just very proud of them. After this, we have, so then I'm moving into the diversion truancy program overall report for 2025. I am blown away by the progress and the success of this program in such a short amount of time. We have really seen some success stories come out of this already. So within 2025, we received 37 total referrals for the program. And I know Lorraine and Judge Smith, they like to see the breakdown of how many are Native American youth and how many are non-Native American youth. So I broke that down to 82% of the referrals were our Native American youth, and 18% were Caucasian or other race. The outcomes of the program, 91.89% of youth referred are considered improved or successful. We have implemented a newer as of the beginning of the school year, where we started to basically do our own student recognition, kind of a student of the month like schools do. And we have found this very valuable, and I mean, watching the reaction of families and caregivers and our students, because the kids we are working with in these programs, they aren't the typical kids who will typically get that recognition and get that award and be told good job. And I mean, we've had mothers in tears because we are really recognizing these kids for where they're at and the progress they're making. We have had 3 students who were nominated for the We See You Award from Sawyer County here. And then in January, we also recognized 1 additional student. So all of the students we've recognized so far are our Native American youth. And, the feedback we're receiving from Judge Smith and different entities within LCO is, wow, this program is really making a difference. And I'm really proud. I'm really proud of the work we're doing, and it is making a difference in our community. 5.41% of the youth enrolled did end up with delinquency referrals, but it seemed to be a wake-up call for those youth, and they are now doing a lot better than where they were before they entered the program. 8% of youth enrolled in diversion were considered unsuccessful, but those were also students that moved away and out of Sawyer County. So I think by looking at those numbers, I know I've talked about truancy being typically a really hard beast to tackle, but I would say with the lower numbers of 8% being considered unsuccessful and 91.89% being improved or successful, I think that speaks volumes to the success of the program throughout 2025. If you look below, there's just different graphs that outline how many referrals were received from each school in 2025. And then the 100%, 70%, 60%, those are how many students achieved 100% attendance, 70% attendance, or 60%, et cetera, throughout that. Any questions on any of this? I know it's a lot. Okay.
I think you've done a great job, and it shows to the children that you care.
Definitely. I've made a statement with whether it's talking to Julia or during interviews that to come and work with me in my department, it can't be just a job, a 9 to 5. You have to have the passion and the heart that goes with it, because if your heart isn't in it and you're not truly caring about the mission and the community, you wouldn't see the success rates we have. So it's very much the right people in the right spots.
Great, thank you.
Okay. Are you ready to move on to economic support?
Yes.
Okay, so Shauna has her report. I don't think Shauna is on. Am I correct? Only Alicia? Okay. One of the things that we did talk about was a potential follow-up on the child care integrity of the program. And of course, today I actually found a press briefing from January 14th talking about that. But I can really put that in for next time. I think what's important to just be able to talk about today is just to let you know that Wisconsin was in not such a great place a number of years ago, back in 2009, started to identify that there was quite a bit of fraud in the system. And so changes have been made along the way to be able to prevent the fraud. One of the big things that Minnesota got in trouble for is they're paying the daycare providers directly, and so there's a lot of fraud that was happening, saying that there was kids there, or it really wasn't even a program. One of the key things, and there's more to it than just what I'm saying here, and I'll make sure I get that included in next month's packet. But one of the key things is the subsidy goes directly to the parent on a debit card, and then the parent pays the daycare with that. So it's kind of a two-person check that there is a kid there and the parent covers there. There's quite a few more things that are in place there, but we are not doing all of those direct payments. We're also having annual visits, drop-in visits, where they're expected to produce all of the data and the information to show attendance and all those types of things. So anyways, just wanted to let you know that apparently I didn't realize that Wisconsin had already dealt with this a number of years ago. Apparently there's a lot we were in the press pretty big, and those things have been resolved. So again, I'll put that in there. Does anybody have any other questions?
Thank you, that's good to know.
Yeah, because you kind of always wonder, right? And one of the other things that we'll do at one of these meetings is bring Shauna in, and she can talk about fraud investigation and how that works for our economic support team. Okay. Public health. Oops, sorry. Okay. Are you ready to move on to public health?
Go ahead.
Or did you have a question? No. Okay, sorry.
Good evening. I just want to highlight a few things in my report. Looking at regional respiratory activity, it is high right now, but it is decreasing. So that is an update from this when we were very high and increasing last week. We're now, I think, on the decline, which is good. Measles, definitely in the news. Nationally, we have 733 cases, which is very, very high within 5 weeks of 2026. That's compared with 2,276 cases for the entire year last year of 2025, which was also a very high year, a 30-year high, actually. So we're seeing a lot of cases, predominantly in South Carolina currently. We do have 2 cases on the Wisconsin dashboard for measles, and another case that was just put in a press release for Walworth County. So we we are seeing cases this year in Wisconsin. I did want to highlight in my written report notes that the Schwamigan Environmental Health Consortium was placed on conditional status in January, but I want to give a current picture of where we're at today. As of this afternoon, we have 921 licensed facilities. Of those, 27 are overdue, which puts us at an overdue rate of 2.93%. The state has said that we need to remain below 5%, and we are below 5%. Of those 27 facilities, 22 are seasonal facilities, or they're closed or not in operation right now, so we're unable to inspect them. 2 have scheduled inspections upcoming in the next weeks, and 3 we're working to make contact to get in those facilities for inspection. And looking at the fiscal year, of those 921 licensed facilities, so fiscal year runs from July 1st to June 30th, we have inspected 629 facilities of those 921. Just to give you a comparison, we're 32 weeks in that fiscal year, which is really 61.5% through the year, the fiscal year, and we're at 68.3% of our facilities that have been inspected. So we're working ahead of schedule on those. 9 of our facilities have been inspected twice. We're working through efficiencies, including mapping, being more strategic with travel time, file reviews, improving our processes in the field. And Julie already mentioned that we have an LTE position posted to make sure that we maintain adequate staffing to continue to provide good services to Sawyer County. Any questions?
Of the 921, how many are short-term rentals?
Oh, and I didn't bring that with me.
Well, it would be about 600 some, so.
That's a good estimate. That's an estimate, but not a.
It's not a
definitive because the code just recently changed, right? So it was enacted the last week for 72. So that changed categories and that increased some TRHs, right, with that change. So it is a little bit above 600, but I don't have the actual number, but I can bring that if you're
So
interested.
that's pretty much stayed stable. Because I think when we first had a report, Matt said that there were like 600.
Yeah, they've come and gone. They've kind of, some of them have changed, but it's about that number, yes. Yep. Despite some of the changes or the ordinance and different things where we thought we might lose some, and yeah.
Yeah.
So when this report came to you that you were deficient in some areas, what were the highlighted areas of deficiency?
So that report was looking at about 9 months' worth of data. And in the beginning of last year, we were behind on a number of facilities. We had more overdue facilities than we have now.
Oh, inspections.
Inspections, yep. And an overdue facility is considered 1 year and 1 day since the last inspection. So anything over that would be an overdue. And we did have higher overdue rates. We did hire, we brought code enforcement on, and then we also hired and trained another LTE staff, which really helped. That was another area identified that we potentially were understaffed and not staffed appropriately to provide that. Also with file reviews, they look at all our data. And we're working with actually the consortium as a whole is working through a corrective action plan to make sure that those are in full compliance.
So when they kind of went back with this, they looked at the whole 9 months. In the last quarter, everything is looking a lot better, but they looked at the whole thing. And like Julie said, it wasn't good at first. We hired up. It took us a while to get everything on board. We weren't expecting.
No, we had made
a corrective.
We had made significant improvements, especially as Julia mentioned, within that last quarter to knock out a lot of those overdues. But in their closeout, it was looking at the whole picture.
So this LTE, is that person continuing employment?
We had hired a LTE. That person is not coming back on. We have it posted already for the next seasonal position to
That's
be able
what
to
you
get that in.
I thought we
Yep.
still have a vacancy, right, for that position?
Yeah, it just got posted, like,
Oh, okay.
it just got posted, so there was. So the person was seasonal. I mean, because frankly, we don't need extra people right now. We can't get into places to go see them. A lot of places are seasonal, so we really need to push things out. And we also have water program, DNR program that we have to run at the same time during seasonal. So there's a lot of things that happen in the mid-year. So having somebody that's just here for a portion of the time to push things forward. Also with Chaz, with ordinance enforcement, getting her on board. She's here all the time, and we can shift her work and get her on. So it was something that we brought on later in the year.
I noticed with communication that in the water testing, they are going to require additional testing. And is our laboratory able to do that?
We will be,
Nitrate?
we'll
I
be
think was-
sending the nitrate out. We send the nitrate out now. Actually, we've been talking about this probably for a year or so because we were anticipating nitrates coming on. We've been talking to other counties, and I don't know if we don't know if it's really going to be cost effective to be able to bring nitrates on. We'll look at it more once we have all the changes in all of the code and we are not like battling all of these other things. We want to be really good at what we're doing before we bring on one more piece. So we're moving in the right direction, but we'll send out just like we do already. We already send them out. The other implication is if we don't send them out, then there's a lot of other expenses that we use Oshkosh and Stevens Point for,
Stevens Point, yes.
where those expenses would go up if we weren't using them for nitrates. So
So I think the fee went up $5. Is that going to cover the?
yeah,
The
when we
cost of-
redid all our water fees for that year when we did the TN and the water, that was inclusive of what we need to do.
Okay,
So we are going to be covered.
okay. Thank you.
Thank you.
Thank you, Julie.
Were we going to talk about the changes in the dead cap that came out with short-term rentals
and
and
the-
hotel motels and?
We weren't going, we could go into a deeper dive at one point. It might be better to kind of wait 2 months for that. The code came out, and the nice thing about it being a slow season for us right now is they've been really all mulling over the code change, because there's not only changes in what establishment is what, but there's also marking instructions and inspection instructions and things that are changing as well. So maybe we can highlight some of those key changes after we've kind of put those into
Okay,
effect.
all right. And then they would start for you in April, correct?
Some of the changes are like now, so we're trying to get, nitrate is like, if we go out and do a TRH right now, nitrate we need to get. I don't know, I haven't been sitting in the marking instructions, but there are other things that are taking place right now.
Okay. Shall we move on to economic support?
We did that already.
Okay.
We're
Good.
on fiscal, we've kind of covered, I know Mr. Schuman asked a
I'm behind
number of
myself here.
questions
Budget performance
Yep.
report.
of where we are. I think the key things that we keep saying is out-of-home expenses, that we need to, we're really kind of honing in on. The other thing that we're going to be working on, like I already talked about, is what's happening with those Chapter 55s, because those were out of county placements. We just need to make sure, one of the things that I want to make sure on is that we've got a lien and we've got something in place so that when somebody sells their house and they owe us money or sells their assets, I'll be probably looking to Mike to like, how do we do that? Make sure that we're in place fiscally, because that's one of the questions that I've asked my team, and I'm not as confident, like, do we have everything in place? So the next step is to go to county fiscal to make sure that we're recouping those funds that we've spent in the last quarter, really, of 2025, because we want to get that back into our coffers in '26. So those are my big takeaways on things that we need to be looking at as we move forward. And we reset all of our things for Fund 258, so we should be good with the Agent Water Program. Anytime we can identify any changes in fees that we should be making without making it, to your point, we don't want to make it so people can't receive services because our expenses are so high. But we need to try to do what we can to cover our costs in ways that we can, and at least get them in programs that we can bill for.
Was there something in the budget that we didn't account for, we didn't have a line item for, and then it was starting to hit us?
We didn't have a line item on the 55s. I don't think we
Okay.
chaptered anybody in the last 2 or 3 years that we had those expenses on. So when you look at your budgeting, you're always looking at your previous years or number of years' expenses.
Right.
And that hit us sideways. We were not anticipating that.
What was that?
The Chapter 55s.
Oh, okay.
The Chapter 55. So those we have a potential to be able to recoup on with those, but like the Chapter 51s, those are more difficult to recoup on, especially when they become a commitment versus just a chapter. So the other thing is the IMD. I did mention about that a little bit before, but the waiver has been put in by the state. I did check today, they haven't seen anything coming out yet, but they're hoping to anticipate that they could have a decision made this year. So if that happens, anybody with medical assistance between ages 21 and 64, their medical assistance will cover them. Right now, the way the federal law is written for medical assistance, if they go into an IMD, which is over 16 bed behavioral health hospital, so if there's over 16 beds there, medical assistance doesn't cover if you're between age 21 and 64. The county has to pay that whole fee. So that would be huge for us, for all counties, if that shift can be made. So last year, I think it's been at least 12 months now, the state finally did a request to the feds to say, hey, can we get a waiver so that we can use medical assistance to pay for those? So, and that's where trying to align, where do we put, if a person needs to go in emergency detention, where do we put them? And how do we do that to best take care of their insurance, or what do we have for county contracts over there? What are our best rates that we can get? Some rates are higher than Winnebago, as we found out. It's like, we did negotiate down to Winnebago rates, but I won't be able to keep that negotiation there. It was a one-time, because we didn't have a contract with them, and I think they had to take what we would give them. So that's what I have.
All right.
Anything else?
Do we have anything under board-appointed committee updates? Anybody? How about correspondence reports from conferences or meetings? Anyone? Future agenda
You're sitting on
items,
this
anything
side
that
of
you'd
me,
like
so
to
I'm
see?
You don't get my back.
Did you have something that you want to see on a future agenda?
I'm thinking about that.
Your lights on.
This is I know, I'm sorry. Very informative though, Julia, all your staff and all the reports they bring to us.
We have a great team, and I'm very appreciative of everybody. We couldn't do it without them, so thank you.
Let's adjourn.